Good evening, all. Today we would be discussing hematogenous osteomyelitis. So the first thing would be, of course, definitions, classifications, a bit about debridement, not a bit, quite a bit about debridement. Then there would be a case discussion related to the concept of appropriate debridement. Then we will have delegates cases. Dr. Aditya Menon had already suggested that people who have posted cases on the group can make presentations. Then I would share a case which I had already shared with you, but I'll show the complete presentation about what else could have been done. Then there is a small puzzle, a case with puzzle. And lastly, I will show you something that nature can do, wonders that nature can do. And lastly, summary. So these are just caveats. There would be different opinions, but respecting opinions is friendship. So obviously there would be more than one opinion for a particular case. Now, the first question was asked whether it is a definite osteomyelitis or a probable osteomyelitis or a likely osteomyelitis. Now, these criteria were laid down way back and almost 50 years ago. Morey and Peterson's criteria. A definite osteomyelitis is the pathogen is isolated from the bone or adjacent soft tissue, and there is a histological evidence of osteomyelitis. So you culture as well as, or you have histological evidence of osteomyelitis. But isolation of pathogen is important. Probable osteomyelitis is blood culture is positive in a setting of clinical and radiological features of osteomyelitis. That means clinically and radiologically it is osteomyelitis, but blood culture is positive. And lastly, likely osteomyelitis is with typical clinical findings with definite radiological evidence of osteomyelitis, and the patient responds to antibiotic therapy. That means only after patient has responded to antibiotic therapy, then you would consider it as case of osteomyelitis. So the first case was we had isolated Staphylococcus aureus, and therefore it is a case of definitive osteomyelitis. Now, what is osteomyelitis? It is infection of the bone characterized by progressive inflammatory destruction of bone followed by apposition of new bone as a part of reparative process. That means the bone is infected, possibly by either bacteria or fungus or virus, whatever, by a pathogen, and there is a destruction of bone followed by apposition of new bone. Acute osteomyelitis, I mean, we have been talking of acute and chronic osteomyelitis. Acute osteomyelitis is a recent infection that causes systemic inflammation. That means patient generally has fever, severe pain, the counts are raised, ESR or CRP is raised, and so that suggests that there is a systemic infection. While chronic osteomyelitis is presence of either sequestrum or involucrum as a result of infective process involving bone. Now, this we have been discussing for ages, acute and chronic osteomyelitis. So in our question, we always think whether I am seeing a case of osteomyelitis, is it a case of acute osteomyelitis or a chronic osteomyelitis? Now, last few years, there has been several new ideas, and this is one article which I share with you, evolving concepts in bone infection, redefining biofilm, acute versus chronic osteomyelitis, the immune proteome and local antibiotic therapy. Now, this article as well as several other articles, they say that even though we have been defining acute osteomyelitis as infection what causes systemic inflammation, and theoretically, therefore, it settles after just draining followed by antibiotics. That means it is an acute infection, there is pus, you drain it, and the patient settles. While chronic osteomyelitis, by definition, as has been going on for quite some time, it is infection of longer duration with minimal systemic symptoms and presence of key pathological features like lymphoplasmacytic infiltration, myelofibrosis, and reactive newborn formation. Now, next few slides are very, very important. There is hardly any time that can be defined as acute changing into chronic. It is sometimes defined as early as 4 weeks since initial disease or as late as 6 months, and generally requires surgery. So there has been a lack of scientific rationale for selection of specific time point, causing a lack of consensus among medical professionals. That means there have been several definitions of or criteria for acute and chronic as regards time is concerned. Therefore, the authors say that we must avoid this time-dependent classification of osteomyelitis. That means we should not say it is acute osteomyelitis or chronic osteomyelitis, not only because of there is not appropriate literature evidence, but there is extreme patient-to-patient variation and pathological variability at cellular level. There is lack of definite methods to effectively discriminate whether it is acute or chronic stage without biopsy and histological examination. And even in histological examination, it is very difficult to know whether it is acute or chronic. So therefore, they have concluded that treatment protocols based on such definitions are almost meaningless. What I suggest, what I mentioned was, in the same case, in the same high power field, you can have an acute inflammation at one place and chronic inflammation at another place. And therefore, whatever may be the stage, especially in periprostatic infection and even hematogenous infection, the patient is at risk for soft tissue abscess formation, biofilm formation, especially on implant, and cortical bone colonization by bacteria. That means don't even think of whether it is acute or chronic. Treat it aggressively. Treat it considering that there is likely to be soft tissue abscess and most important biofilm formation, which needs removal. So to recapitulate, initially the bacteria are in planktonic form. They get killed by antibiotics. Whatever are remaining get killed by body's defenses. When there is a traumatized tissue or avascular tissue or poor host defenses, then bacteria start sticking to the surface, something which we did discuss last time. They secrete extracellular matrix and get embedded in biofilm formation. The metabolic rate goes down, inflammatory markers reduce, they develop pathways for nutrients, and then body forms pus, which is a thick yellowish or greenish opaque liquid produced by infective tissue consisting of dead white blood cells and bacteria with tissue debris. So it is tissue debris with dead bacteria with white blood cells, dead or living bacteria with white blood cells. Generally, it is yellowish or greenish. Most commonly found in acute scenario. However, we are not going to differentiate between acute and chronic scenario. Why? Because we don't know at what point of time the bacteria form biofilm. They may form at 5 days, 7 days, 10 days, or sometimes later. But even at 5 days, you may have a biofilm. And therefore, if we make a small window, I shared a case where I had made a small window and I drained pus. What remains inside is a significant biofilm, and therefore the culprit still remains. A generous window to remove biofilm is absolutely necessary. Moment you remove the biofilm, the bacteria go back, whatever are remaining, go back in planktonic form, which can be removed. So, friends, remember, there is hardly anything like acute and chronic osteomyelitis, especially in adults. In pediatric age group, the blood supply is so good that very often in early cases, one can drain pus and patient settles with antibiotics. But at least as far as adults are concerned, there is generally, there is no scope for just draining pus by making 1 or 2 drill holes, draining pus, draining a soft tissue abscess, giving antibiotics, and expecting the lesion to respond. I will stop sharing at this stage, and there seems to be one. Oh, fine. So now I'll request Dr. Aditya Menon to discuss about features of MRI features of osteomyelitis and various classification systems. Dr. Menon, please.
Thank you, sir. Two basic classifications, that's Cerny, Mader, and Bach, the newer Bach classification. The wrong screen. Yes. The age-old Cerny Mader classification, we've been taught this throughout our MBBS and orthopedic practice. It's something we tend to forget because we don't practically implement it. Now, what it essentially describes and what the original authors described was the anatomical involvement and the kind of host. Now, from any classification, what we would want to know as surgeons is how would we clinically use that classification. Now, what Cerny Mader has described and based on which a paper was published in 2014 was stage 1. Let's look at the anatomic classification first. That would comprise into 4 stages. Stage 1 would be purely medullary infection. These kind of infections are seen more often in pediatric osteomyelitis, spontaneous hematogenous osteomyelitis, and also after infection with a nail. So the entire medullary canal gets involved. The second type is a very rare and uncommon type of osteomyelitis that is a superficial type. Only the cortex is involved. The medulla remains normal. There is no medullary involvement. That is the peculiarity of this kind of osteomyelitis. It is probably seen in very early stages, and by the time patients come to us, there is some evidence of medullary involvement as well. So it's very uncommon we see. Third type is a localized osteomyelitis, wherein the superficial osteomyelitis involves the medulla as well. But there is axial stability. If you look at the 360-degree axial cut of that bone, only one cortex would be involved, the other cortex would be intact. So there is no axial loss of stability. Whereas stage 4 would be a diffuse involvement at that level. So there would be a loss of axial stability. An infected non-union would come in a type 4 kind of a diffuse osteomyelitis. As far as the treatments is concerned, clinically we can say that stage 1 would be removal of the nail and draining, or in a medullary osteomyelitis in a pediatric case, make a cortical window and scrape or do a medullary reaming. Stage 2, where we have superficial osteomyelitis, we should ideally remove or saucerize the cortex till we get viable bleeding bone. Try and not expose the medullary canal, because then we would be introducing the infection from outside to the medulla, where in cases in type 2 where the medulla is that way uninvolved. Stage 3 would be cortex and medullary involvement, like I said, but with no axial stability. Again, it would involve debridement and removal of that necrotic bone and the scraping of the medullary canal at that region. And stage 4 involves axial instability. You have to treat it like a classic non-union, excise all the necrotic bones from both ends till we get fresh bleeding edges, along with the soft tissue debridement. As far as the host is concerned, there are 3 types of host: A, B, and C. logically A would be normal and C would be the worst. So A is a normal host. B is host with some compromise. Now B is divided into three subtypes. BS means a patient has a systemic compromise. I'll just tell you the details of it in the next slide. BL would be a host who has local compromise, and BLS would be a host who has systemic as well as local compromise. And type C would be a host who has severe medical issues like cardiac or renal issues where operation would be more dangerous than conserving. So patient who's severely morbid, where anesthesia and surgery itself poses a threat to life, would be classified as a type C host. Now, BS on the left-hand side of the screen would see systemic issues like malnutrition, diabetes, which is very commonly seen, malignancy, extremes of age, or immunosuppression, along with tobacco abuse. So, the minute a patient has oral tobacco or smokes or has pan with tobacco, then it gets classified as a systemic compromise. Local compromise would be chronic lymphedema, major vessel issue, or a small vessel like you would see in a diabetic microangiopathy, vasculitis, venous vessel, extensive scarring, and neuropathy. So I'll just show you this case where a 70-year-old male had own case of had chemotherapy, had a UTI for 1 year for about 6 months ago, presented with pain and swelling on the shin. Now, this is the osteomyelitis. Here we can clearly see that it involves only the superficial cortex, the medulla is uninvolved. So it would be an stage 2 or type 2 kind of a Sony-Meda classification, and a BS, that is a systemic issue with chemotherapy. So that is how we classify Sony-Meda classification. But there were certain drawbacks with Sony-Meda as far as the clinical application. It wasn't very clear what we can do as far as the microbiome is concerned or the soft tissue is concerned. For that, another classification was described in 2019 in the Journal of Bone and Joint Research. It included multiple variables. It's called BACH classification, BACH. What the author said was it had better inter-observer reliability. So BACH is basically an acronym. B for bone, that's the first variable. A is for antimicrobial options, which is not included in the Sony-Meda classification. C is coverage of soft tissue, which again becomes clinically extremely relevant, again not included in Sony-Meda classification. And H is the host status. So out of BACH, B and H were part of the Sony-Meda, and these authors have added the antimicrobial and the soft tissue coverage options. Now let's look at each of these variables. B has B1, B2, and B3. Now B1 is a cavitary infection without joint involvement. It could be cortical, it could be medullary, but it has to be, or a non-segmental corticomedullary. So if you correlate this with Sony-Meda classification, then a 1, 2, and 3 would fall in B1, whereas a B2 is a segmental infection. That means the axial stability is involved, and this would be a type 4 Sony-Meda. So an infected non-human would fall into B2. But B1 and B2 do not involve the joint. The minute the osteomyelitis involves the joint as well, they say this is type 3 because it involves the articular cartilage. So the prognosis becomes even worse. Looking at the antimicrobial options, logically, it would go from less resistance to maximum resistance. So A1 would be either culture negative or all isolates sensitive to more than 80% antibiotics, or resistant to less than 3. So lesser the resistance, better it is. So if you see the antimicrobial sensitivity report, if it's less resistant to less than 3, it would fall into an A1 isolate. A2 would be resistance to 4 or more antibiotics, or resistant to antibiofilm antibiotics. So antibiofilm for staphylococcus would be rifampicin, we had discussed this last time, and an antibiofilm antibiotic for a gram-negative would be ciprofloxacin. That means the oral antibiotics or a Ceptran are not available. A3 would be a bacteria or an organism sensitive only to one, or a pan-resistant organism, and we are seeing this more and more often. So that would be the antimicrobial options going from least resistance to highest resistance. As far as soft tissue coverage is concerned, there are two, C1 and C2. C1 would be direct closure as possible. That means the extent of infection is less. If the extent of infection is much more and we have to excise a lot more tissue, because of which we need some kind of plastic surgery, then that comes into a C2. Looking into the host status, H1 is a when-controlled disease, or patient is well infected. So a patient may have diabetes, but it is well controlled, or a hypertension, well-controlled cardiac issue, not decompensated, then it would come in H1. H2 is a poorly controlled comorbidity or a severe comorbidity, like an end organ damage. Patient on dialysis would be classified into this. Or a recurrent osteomyelitis with previous diploids. A lot of our patients come to us after the previous diploids. They would automatically fall into H2, even if they do not have any comorbidity. Simply because the complexity of the surgery increases. There is fibrosis, there is scarring, there is extensive involvement of the bone and soft tissue. And H3 would be unfit for definitive surgery or a patient who declines surgery. Again, all these variables go from less complex to more complex. Each of these variables, bone, antimicrobial, cover, and host, has three bands: green, orange, and red. Green is uncomplicated, or amber or orange is complex, and red band is one who is limited or no option. Looking at each of these, all the ones, B1, A1, C1, H1, logically fall into uncomplicated. B2 or B3, A2, C2, and H2 fall into complex. That's the next level. In antimicrobial and host, the minute it becomes extremely drug resistant, or the host is highly comorbid, where the surgery would be more detrimental, it becomes a red zone or a limited option patient. Now, interestingly, what the authors have said is that the patient must be classified based on the most severely classified variable. So even if the patient has B1, but the bacteria is resistant to all antibiotics or only one sensitivity, that means he would automatically fall into A3. So the patient goes into the red zone. It doesn't depend on combination. It depends on the worst factor. So if the patient has direct soft tissue closure but has limited antibiotic options and falls into A2, it would be an orange band. So look at the most complex aspect, and that is where the patient gets classified. What they have also suggested is if the patient falls in the green zone or an uncomplicated zone, it can be treated as a non-specialist center. Whereas as the complexity increases and the patient goes from an orange to a red zone, preferably transfer the patient or refer the patient to a center where multi-speciality, because the patient would logically need plastic surgery or an ICU backup or medical specialist for the relevant medical issues. That would not be manageable at a smaller center. So that is how this classification becomes even more clinically relevant. As far as predicting the outcomes based on this classification, there was a study based on this paper where patients had to assess on their own the quality of life at 2 weeks, 6 weeks, 120 days, and 1 year. Patients themselves had to assess. What they realized, and again, this is logic, B1, that is uncomplicated bony involvement, had much better quality of life than B2, significantly better. Looking at the antimicrobial, patients with A1 had significantly better quality of life than patients with higher antibiotics or more resistance. Again, the treatment complications may have been more with these bacteria, or the side effects with antibiotics may have been more. Patients may have had to take IV antibiotics for a longer time. All these reduce the quality of life. So A1 gave a better quality of life. Interestingly, plastic surgery or wound cover did not change the quality of life. So that means if the patient required a flap, did not change quality of life simply because we've got rid of all the infected material, and the flap or the plastic surgery gave the patient an equal quality of life as would a direct closure. H1, again, patients with lesser comorbidity had higher quality of life. How many came back to normal? Again, that's a very important question. We say that patient has infection remission, but functionally for the patient to go back to normal, the minute he came into a complex criteria category, just 1 out of 4 returned to full health status. So it's very important to tackle them early, diagnose them early, and treat them appropriately in the initial stages so that they stay in the uncomplicated state and they get a better quality of life and return back to normal. My third talk would be on the MRIs. In short, we'll summarize what are the basic MRI findings that we must look at. Now, we know in MRI there are 2 sequences mainly, T1 and T2. The third part that I've shown in this slide is T1 plus contrast. Now, this is something all of us must realize that it is not just about doing an MRI. Contrast enhancement gives us so much more than just T1 and T2. We'll see how. unless the patient has high creatinine and creatinine clearance is hampered. Otherwise, in all patients, a contrast MRI must be asked for if possible, if the facilities are available. Now, looking at bone marrow edema, intraosseous abscess, or a subperiosteal abscess, all these things are abnormal. On a T1 image, they would all appear black, that means low. On a T2 image, they would all appear high. So let's remember this simple thing. Anything abnormal in osteomyelitis like bone marrow edema, an intraosseous abscess, or a subperiosteal abscess would be black or hypointense or low on T1. And they would all be high on T2. A trick to know on the MRI sequences, a lot of times the MRI film show TR, that is T relaxation time. If the TR value is in thousands, that means it's a 2:2 image. And when we look at the T1 contrast, bone marrow edema, now a trick to remember contrast interpretation is contrast is wherever the blood goes, contrast will go. Wherever there is no blood, contrast will not go because contrast is injected intravenously and flows through the capillaries in vein. Now, bone marrow edema obviously has blood, so the contrast would be high, that is, it would be bright white. Any abscess, now the center of the abscess is pus or a cystic lesion has fluid. That fluid or pus has no blood. It is the surrounding envelope or the granulation tissue which has blood supply. So that will enhance. So it will be a peripheral enhancement called as a penumbra sign with a black center. So a hypo or black center and a high signal at the periphery. That is how we can differentiate a hematoma. A hematoma would be completely white on contrast because it's blood everywhere, whereas an abscess would be white outside a ring and black in the center. That's why contrast is important. Looking at the other aspects of osteomyelitis, cloaca, what is cloaca? It's a defect that allows pus to flow between bone and soft tissue. It's low on T1 because it's abnormal. It's high on T2 and low on T1. Why? Because it's just a tract. There's no lining. It's just a defect in the bone. So it's low on T1. Looking at a sinus tract, in contrast to a cloaca, it's lined with granulation tissue, draining pus from the bone or the soft tissue to the skin. So it would be low on T1, high on T2 with peripheral enhancement because the lining is alive, whereas the center is just pus. Sequestrum is a dead necrotic bone. It would be low throughout with peripheral enhancement. So it would be low on T1 and T2 because it's dead bone. There are no signals coming out of it from T2. With peripheral enhancement because it is surrounded by granulation tissue. I'll give you one example. This is a T1 image showing marrow edema. The white arrow on top shows marrow edema, so that's low or black. The abscess in the lower third of the metaphysis, in the lower end of the metaphysis, is again black on T1 image. On the X-ray, you can see the lytic area that corresponds with the intraosseous abscess. Both are black or low on T1 image. As far as the T2 image is concerned, both are white, intense, high. So the white arrow on top is the bone marrow edema, the black arrow below is the abscess. Now look at the contrast. In contrast, the marrow is still white because the blood goes there. And the lower part, the center is black or hypo because the pus does not have blood. But the surrounding is white because it has peripheral enhancement. Another important thing that we must differentiate is osteomyelitis and tumor, especially in pediatric cases, they become very, very difficult to understand. In contrast, especially in these cases, contrast becomes important because in osteomyelitis, we get a penumbra sign, low center, white signal outside. In a solid tissue, it would be a heterogeneous enhancement because there'll be solid areas, there'll be necrotic areas, there'll be vascular areas. And in cystic lesion, it will be same as a peripheral enhancement. So cystic lesion, one may be able to differentiate on an X-ray on an osteomyelitis versus an aneurysmal bone cyst or a simple bone cyst. Because the cystic lesion, again, center is fluid and the surrounding is healthy tissue. But whenever in doubt, always biopsy. And the one thing we must remember is whatever we biopsy, we must send for culture and histopathology. Because if the culture is negative in a tumor, it's obviously going to be negative. It's the histopathology which will give us the actual causative pathogen. So this was as far as the MRI findings are concerned.
Thank you very much, Dr. Aditya. Friends, we did discuss various classifications, especially BACH classification. And antimicrobial sensitivity is vitally important, something which was not considered in Sarni-Medar classification. I am happy to inform you that our paper dealing with carbapenem resistant gram-negative bacteria is now published in International Orthopaedics Journal, International Orthopaedics. The title is Carbapenem resistant gram-negative bacteria stroke early compromises save life. These have a very high incidence of mortality, while we decided that life is more important, life before limb, before function. So we compromised as regards length is concerned, alignment is concerned, but that way we could save lives. So I'll share that paper with all of you. Secondly, there is a question from Aisha Mohapatra. How may we know muscle involvement or necrosis in sequence of MRI? Next time or in between the modules, we will share some pictures rather than just describing without pictures. Now we will go to the debridement. OrthoTV, can you start sharing? OrthoTV? OrthoTV there? Dr. Menon, can you just keep contacting?
Yeah, I'll do that.
Now, there is a question by Dr. Akshay. After making a window to drain pus or remove biofilm, do you recommend to close the wound completely, or should we keep the wound open and do a secondary closure? If you are exploring for and the infection is significant and you are planning to come back second time, then it is best to loosely close. Don't keep it open, but loosely close and come back after 3 or 4 days, especially after getting the culture sensitivity report. Occasionally, there could be excessive hemorrhage, and in that case, we may have to pack the wound and come out. That's a different story. But otherwise,
yes, Dr. Agash, yes, I'm here, sir.
Yeah, please share the screen.
Just 1 second.
Yeah. Unfortunately, my computer is giving trouble when I share presentations with the video, and therefore I have shifted the presentation, mailed the presentation to OrthoTV, and then I'll speak while they will run the presentation. Can you go to slideshow? Can you go to slideshow, please?
Can you see it? Can you see it, sir?
Thank you. Thank you. I have shared a paper on debridement by Kevin Texford and Sirni himself. And they say that it is an underappreciated aspect of management, but most important. And they also mentioned that this is also under reimbursed component or aspect of management of any orthopedic condition. You do a total joint replacement, the reimbursement or the surgeon amount surgeon gets is pretty high as compared to debridement. And that's a very unfortunate story. Next, please. So the idea is try and remove everything that is infective or dead. Next, please. Very, very occasionally, you may just drain the abscess and come out in very early cases, as we discussed. Next, please. But in most of the other cases, one has to extensively debride. So I will discuss this with a case presentation as well as video. So this 70-year-old diabetic patient presented with discharging sinus over left thigh of 8-month duration. He gave history of osteomyelitis left femur in childhood, for which he was operated, and as per the history, he had possibly developed a fracture. He has been having repeated episodes of discharging sinus, and he has taken multiple antibiotics and there is no relief. So generally, next please, generally a very uncomfortable patient with scar which is adherent to the femur. In the center, there is a discharging sinus, and he has a decent range of movement, and he is weight bearing, fully weight bearing. Next, please. So that's the X-ray. You can see there's a healed fracture. In the center, there are some small sequestra. The most logical thing is getting investigated further. Next, please. So we did a CT scan. Also, important thing is it shows a sclerotic bone in the middle, and it shows a cloaca through which there is a connection to the discharging sinus. Next, please. So same in sagittal view, you can see there is a mal-united fracture. Next, please. Let's say axial cut. You can see there is a cavity with a sequestrum and there is a cloaca. Next, please. That's the MRI, shows signal abnormality. That Dr. Menon had said there is a generally in T2 or in T2 contrast, you will have a hyper intense, the marrow will be hyper intense if there is infection. So here you can see there is a hyper intensity in the marrow, and there is a cloaca. It is also containing pus, and you can see it is coming out from the lateral side. Next, please. So what is our surgical planning? Preoperative assessment of this case is very important. You need to address three important things. One is a good source control. So you need to anticipate from where the infective tissue is coming. Secondly, you need to plan for a soft tissue cover. And thirdly, you need to plan for dead space management as well as support. Next, please. So anticipate where the infective tissue could be located. Next, please. So in the soft tissues, next, please, and in the bone. So in the soft tissues, the pus can be in the previous incisions. Remember that drain site as well as connection between the incision and the drain site, that entire tract is generally infected. So you need to excise everything. The sinuses and scars generally have infective tissue, and of course, there would be soft tissue abscesses. They may not be in continuity. They can be discrete. They can be multi-loculated soft tissue abscesses. And quite often, they track along the anatomical structures. In the bone, the granulation, infective granulation tissue would be at fracture and non-union site, would be in the medullary canal, the cloaca, lining of cloaca. Then very often there are intracortical abscesses opening superficially and in the medullary cavity. And if there is an implant, it could be underneath the plate or along the nails and in the screw holes. These are the commonest sites which have infective tissue, and each of that has to be addressed. Next, please. So after thinking about it and after studying these images, we develop a surgical plan. It is best to draw a picture like this. And what is our plan? You can see that's these are the lateral side muscles. That's the cloaca, and which is communicating with the infective tissue inside. Next, please. So what is our planning? excise this infected tissue. Next, please. From the beginning of infected tissue to end of infected tissue. There is no point in just making a window as we discussed. After that, it is equally important to release these muscles, mobilize them, and get a good soft tissue cover. This is possible generally in thigh. In the leg, you may need a flap cover, or you need to plan for a flap cover. Next, please. So in this case, after going through the images well, we decided to create a window of about 9 centimeters. And next, please. Now the question again, why make such a window? Why not widen cloaca and scrape locally? How to avoid stress fracture? And what is the fate of window? Next, please. Next, please. So remember, size of window determines the completeness of surgical procedure. Unless you have an adequate size window, you will not be able to complete the surgical process. While shape of the window determines a possible fracture. And a pathological fracture can be a result of both. So what do I mean by shape of window? Traditionally, we have been making square windows or rectangular windows. Remember, the windows have to be elliptical. The ends have to be rounded off so that there is no stress riser. We'll stress that with our cases. Next, please. Next, please. So this is a case that I have shared with you. I did a small window and he fractured. Next, please. Next, please. So that's the position, lateral position. The bony prominences need to be protected well. This is a gel pad which is over the, underneath the lateral malleolus as well as trochanter. Next, please. It is best to cover the orifices well. Next, please. And this is after preparation and draping. Next, please. So that's the sinus tract going to cloaca. Next, please. This must be a video. Can you start, please? Yeah. So as we discussed, we need to excise the scar completely. Now, do we take this incision or we take a incision that is taken first? So it is better that you have a elliptical incision, or I can say lip-shaped incision, rather than just a small rounded thing in the center. Next, please. Next, please. I think this is what we discussed. Next. Yes. So once you start taking incision, try and go into the deep fascia completely. Avoid subcutaneous dissection. The corners need to be cut properly. Especially at this stage, there could be a fair amount of bleeding, but don't worry, just keep it packed, keep it pressed, keep the edges pressed, but go down to the fascia. Next, please. Then the adhesions around the cloaca as well as surrounding areas. Very often this deep fascia is stuck to underlying structures, which I am separating. Because finally we have to mobilize the muscle and mobilize the fascia. Without that, without separating this, you will not be able to get a cover. Next, please. This must be a video. Yeah. So here you can see there is a sinus tract that I am holding with a cocker, and it is necessary that you identify the walls of this sinus tract and excise it, the whole thing. That means go along the walls of the sinus tract onto the bone and then excise the whole thing. Next, please. You can see there is a granulation tissue coming out. Yeah. No, just go back. Don't click. Yeah, there is a video there. Yes, let the video run completely. Yeah. So separate that wall and go right onto the bone and excise the walls completely. Next, please. After you do that, now you can see the cloaca and granulation tissue. That is the real important thing that as regards culture is concerned. So please do not take culture from sinus tract. However, the sinus tract needs to be sent for histopathology. Now here you can see the pus. Next, please. Yes, this must be a video. So the sample is taken and marked as sample number 1. Immediately to be transferred to sterile container, as well as part of it can be used for bactec by diluting to some extent. And after you have done that, next please. After you have collected this sample, then you can see the wall of the cloaca is stuck. That needs to be released so that you get a cover. Next. So initially we separated the deep fascia from muscles, and now we are separating periosteum from the bone. And this is the cloaca now. As we discussed, we need to create a window of approximately 9 to 10 centimeters with cloaca in the center. Next, please. So you need to mark the window. Please, this is a video. This is a video. Will you start the video, please? Yeah. Mark the video. Sometimes especially with some blur, the cautery doesn't work, but that's the marking of window. Next, please. So generally, multiple drill holes are drilled. Next, please. Which weakens the bone. Then first, both the ends are osteotomized, or those holes are connected using a 5 millimeter osteotome, and then the window is made by using a 10 millimeter or 10 millimeter osteotome. From the underneath the bone, rather through the medullary cavity, another sample is collected, which can be marked as sample number 2. Next, please. And then the cavity is thoroughly scraped. This gives you an excellent access all around, and you can scrape the adherent tissue, which is biofilm. Next. Obviously, you can't say that this is biofilm. It's a infected granulation tissue. Now, it is equally important to make the window smooth and the ends rounded. Now, I am using Midas here, which is expensive, but good ENT burrs are available for about 16 to 20,000 rupees of various sizes, and they can be easily used to smoothen this cavity. One needs to keep pouring normal saline. Next, please. Next, please. So the window, as I discussed, is made smooth. Next. Starting from here, next to here. A reasonably smooth window is made. Must use a CM, must take a CM picture to confirm that you have done a window as per your plan. Next. Cultures we have already discussed. Next. 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 After collection of sample, empirical antibiotics can be given. In this case, we gave piperazine tazobactam. Next. And what is important is a good soft tissue cover. So here, since we have released the muscles from the bone and released the deep fascia from the muscles, because deep fascia was adherent to the muscles, we could easily get a good soft tissue cover. So in thigh and hip, generally there is no problem. You can mobilize the muscles reasonably well and get a good cover. Next. So this was the culture report. We have already discussed this. Next, please. She was treated with teicoplanin 600 milligrams. We started off initially 400 BD, and at discharge, he was given 800 milligrams once a day. Next. Now, what do we do on day 1? What do we do on day 4? There was a question whether we do a proper formal closure on day 1. Remember, there is a big dead space, and that dead space needs to be managed properly. When I was a resident, we often used to have a muscle that was put in there. Now with either local antibiotic delivery system, the dead space can be reasonably well managed either by using PAMA, PMMA, or stimulant. So day 1, what we do is, after a good thorough wash and confirming that there is reasonable hemostasis, we take loose sutures, wait for the sensitivity report, and then put appropriate antibiotics and use it as a dead space management system and close on about 4th day. Now, question is, why not do it on day 1? Agreed that it will save the patient one more surgery, and it will also decrease the load on you. Remember, we have a significant load of resistant bacteria, and therefore it is better to wait. That is number 1 reason. Of course, the local concentration is so high, it's almost 1,000 times that of the concentration of IV. So actually it does not matter. But these are all theoretical things. It is, in our opinion, it is best to wait. And second and most important thing is, very often there is significant bleeding all around, especially from the medullary cavity on day 1. And the local antibiotic is likely to be washed out. And therefore, by 4th day, the bleeding tendency of the medullary cavity decreases. And then you can put in these beads to have a good dead space management. Next, please. It is quite important to monitor patients well and take help of the patient himself or herself in management of this. So we very often give this chart to the patient as regards pain or VAS score of the patient, then whether they have appropriate appetite, their weight, and in case they find that the wound is a problem. But most important is pain. So here you can see on 12/6/21, patient's VAS score was 10, and it dropped down to that is the number of days. By 17th day, it had gone down to 2. So patient helps you to monitor well. Next, please. The same thing is used for patients of osteoarticular tuberculosis, and weight gain helps you a lot in finding out whether patient is improving or not improving. Next, please. So this is the heel scar at 2 months. Next, please. That's the X-ray where local antibiotic is absorbed. Just a hint about this local antibiotics. They generally get absorbed in 6 to 8 weeks time. However, if there is persistent infection, they generally do not get absorbed. So if you see these local antibiotics or stimulant at about 8 weeks or 9 weeks, then it is quite likely that patient still has infection. Next, please. And this is him at 5 months. It's now 8 months, and then patient is very, very comfortable. Next, please. So remember, friends, debridement plays a very major role in management of osteoarticular infections. You need to plan well. You need to anticipate where infective tissue could be located. You need to take it out well. Local antibiotics play an important role. Most important is a good soft tissue cover. You need to plan well. You need to find out whether you can have approximation or closure by yourself, or you will need plastic surgery help as discussed in BACH classification. Thank you, friends. If there are any questions, I'll take them.
Thank you, sir. So there are a couple of questions for you.
Yeah.
First is whether stainless steel implants can be, when we do an MRI, can we ask for an MRI with the presence of stainless steel?
Since last 5 or 7 years, a new software is introduced or new sequence is introduced, what is called MARS, M-A-R-S, Metal Artifact Reduction MRI. And that is becoming quite freely available at many places now. It reduces the metal artifacts, and you will be able to get a reasonable information as regards soft tissues are concerned, soft tissue abscesses are concerned, vessels location is concerned, and intramedullary signals are concerned. Obviously, it is not as good as the MRI you get when there is no metal, but it certainly helps you in localizing the infections.
Yes. Second question is on how many days of IV and oral antibiotics do you suggest? That would broadly depend on the culture pattern. Hello?
Hi, yeah, go ahead.
Yeah,
go ahead.
So Dr. Akshay, that would depend on the culture pattern. If there is an oral option available, what we like to do is give at least 2 weeks of IV antibiotics before switching to oral. There are some papers that say 3 or 4 weeks, but by and large, 2 weeks is the minimum that you should try and give. If there are oral options available, only then. Otherwise, it will be 6 weeks of IV antibiotics. The new criteria for staphylococcus, there are new guidelines which say antibiotics for staph, whether it is MSSA or MRSA, should be for 8 weeks. Beyond that, it is only for uncommon pathogens like fungi, non-tuberculous mycobacteria, burkholderia that treatment may have to be continued for up to 6 months. That's the gist of it. And another question by Dr. Aisha is role of scraping versus intramedullary reaming through piriformis fossa or trochanteric entry.
It depends on whether you are dealing with infection with nail, you are dealing with medullary osteomyelitis, or you are dealing with osteomyelitis which is localized, in the sense there is either superficial osteomyelitis or the osteomyelitis is communicating with the medullary cavity. Now, most of the times, these osteomyelitic processes are in the lower third. If they are in the lower third, the reaming is A, will be inadequate, and B, you will be going through a normal area. The upper 2/3 or upper half of femur is normal. It is not infected. So if you try to ream for this kind of the case that I have shown you, then what would happen is your reamers are going to come in and out through an apparently uninfected area. Plus, you will not be able to get a good source control because the canal is funnel shaped. Your reamers will not be able to ream the walls, and therefore, if you make a window, then you will be able to scrape properly. On the other hand, if you have a nail, then appropriate size reaming is very useful. Now we will of course discuss this in detail when we are discussing osteomyelitis in presence of nail. But it is equally important to remember that if you have done a close nailing and it gets infected and you are taking out the nail and reaming, remember to make a window distally. Just removal of interlocking screws do not give you adequate size holes which will take out the infected granulation tissue. So it is best to make a window distally and allow that dirty granulation tissue to come out.
Next question by Dr. Durgesh is, when he uses antibiotic cement, it causes serious discharge for a few days for traumatic bone loss as well as an osteomyelitis. Why is that?
Yeah, it must be related to stimulant. Dr. Menon, will you like to take this question?
Yeah, Dr. Durgesh, I think
our paper also.
Yes. So we've done a study specifically where we've seen discharge following stimulant use. Now, stimulant is something that dissolves. The calcium sulfate dissolves. And when it dissolves, it causes a hyperosmotic reaction. That means it absorbs more fluid. And that fluid seeps out through the surgical site. Now, that's a side effect of stimulant seen in almost up to 5-10%. As the stimulant absorbs and gets resorbed in the body, the discharge will stop. So it can vary from 10 days to sometimes 3 to 4 weeks. As long as the patient does not have any pain, local redness, swelling, or fever, and there's no frank pus, you can monitor it, and the ESR CRP should be dropping. Just monitor the patient clinically, and the discharge should dry up, provided none of the other things are there. So this is commonly seen with stimulant. Sir, I don't think you have also seen anything with PMMA, was it? I don't remember seeing anything with PMMA, any discharge with PMMA.
No. It is essentially stimulant because it dissolves, and that's the function. It dissolves and elutes the antibiotics locally. Remember, the stimulant has a activity zone of only 2 to 4 millimeters. So there is no point in concentrating the stimulant or any resorbable antibiotic or any antibiotic for that matter only locally. If there is infection from here to there, 8 centimeters, then you need to lay down your stimulant over the entire area. Don't just keep it inside. It is not an IV antibiotic which is given here and will act over the entire area. So our paper, we will share our paper which was published in infection.
Journal of Bone and Joint Infection.
Yes, Journal of Bone and Joint Infection. Journal of Bone and Joint. We'll share that. We had studied 39 cases, and that time we had a high incidence of discharge. Over a period of time, we have made some modifications in our protocol, so as to avoid putting it in subcutaneous tissue, not keeping it concentrated at one side, and then the incidence has gone down to about 5 to 7%.
Keeping it deep to the muscle was the trick, was the main important thing. And next question by Dr. Akshay again is, after making the windows an antibiotic, local antibiotic, complete resolution of infection occurs. Do we need secondary bone grafting to prevent pathological fractures?
I will discuss it with the case.
Another question on bone cement with antibiotic. When do we remove the cement? If we are using PMMA, when do we remove it? For dead space management, whenever we use it.
Not beyond 6 weeks, generally.
I think one of the cases that you're showing, sir, will highlight that local PMMA.
Yes.
Do you recommend protecting the limb in a slab after making the window? If yes, then how long?
Again, I will discuss it with the case. But in short, in general, about 3 months. In general, upper limb, lower limb, partial weight bearing for 3 months. In general.
And can we apply wax after thorough debridement?
Let me just interrupt.
Yeah.
One important thing you have to tell patient is to avoid torsional force. He cannot just turn like this. That is the time when they often get a small spiral fracture. They are generally careful preventing a fall, but they are not very careful as regards turning is concerned. And then they develop a fracture. So you have to instruct them to avoid turning like this.
And next question is, can we apply wax after debridement? After thorough debridement?
If there is not much bleeding, then you can apply. Very often in infected areas, there is a significant hyperemia. And then it is best to apply after about 2 or 3 days.
And if you cannot achieve primary closure?
Yes. Dr. Aditya, will you just explain about how to prevent excessive bleeding if you have scraped the bone with wax?
Yeah. So a couple of things that we must do is after we made the bone window or we reamed the medullary canal, pack the medullary canal with 1-inch roller gauze or 2-inch roller gauze. Keep it packed for 10-15 minutes. That itself causes a lot of hemostasis. After that, avoid applying the foam directly on cancellous bone like a femoral condyle or a tibial condyle after doing a infected knee joint or an infected hip joint. Avoid putting it within the medullary canal. Use a wound contact layer like Bactigras or QP cell, or there's something called as a bone mesh. Basically, that acts as a barrier for the foam to directly absorb all the blood from within the medullary canal or the cancellous bone. Another important thing after doing all that is, if you have somebody in your team or you yourself, has to keep a watch on the canister, the amount of blood collecting in the canister over the next 4 to 5 hours. If it suddenly starts filling up, just stop the wax, apply compression dressing and leave it. There is no point. Otherwise, the patient will actually bleed out all the blood within the wax machine. So instruct your nursing staff, instruct your juniors, or you yourself need to keep a watch. Next question was, there is a myth about stainless steel implants getting pulled by MRI machines?
Yeah. Generally, no.
If we have to make large windows enough to debride thoroughly, we need to stabilize with X-fix or internal fixation. Again, a question on stability. I think you would be discussing that.
Yes, I have shared a paper and they say that if you have about 70% circumference intact throughout the window, there is no need to do an external fixation. I generally like to be little more conservative. If the overall size is about 20% of the bone circumference, then I will not like to put an external fixator.
So if we make a long, thin window, sir, that will give us access enough along the medullary canal as well as not reduce the axial stability, rather than a short, wide window.
Yeah. So I think Dr. Aditya, you can go ahead with your femur case.
Yeah. So this was the third case which was sent as a questionnaire in the Google Sheet as well. The 38-year-old male presenting with, diabetic, pain and swelling in the thigh, was diagnosed to have osteomyelitis of femur based on clinical, radiological, and blood parameters. You can clearly see hyperintense signals in the medullary canal or T2 images with a soft tissue collection. There was a cloaca which was breaking out from the medullary canal into the soft tissue. Clearly a case of osteomyelitis with an abscess. The first question was, how do we classify this as per the stage 1, stage 2, stage 3, stage 4? The response is 50% stage that this was a stage 4 or a diffuse type of osteomyelitis. The other half were between stage 1 and stage 3. Here, next would be the host type, whether it would be a type A, type B, type C. Patient was diabetic. Vast majority correctly answered that this would be a type B. Some of you said it would be a type C. I'll come back to the correct answers as we go through this case. What kind of classification? We know that this is a Cerny-Meder classification. Majority have agreed with that. Very clinically relevant question. If this patient came to you at this stage, would you start antibiotic? Yes or no? Vast majority would start this patient on antibiotics in an established case of osteomyelitis. If not, would you do image-guided biopsy or explore? Here as well, amongst the people who said that empirical antibiotics would not be given, only half would say, or less than half would explore, the other half would do an image-guided biopsy and then start antibiotics. If antibiotics, then which antibiotics? Majority were divided between cephalosporins and piperacillin tazobactam. One covers, we know, gram-positive, the other is gram-negative or a broad-spectrum cover. Now, going back to the case, this patient was started on amoxicillin clavulanic acid by the primary surgeon in an osteomyelitic case. At 2 weeks, because the pain persisted, the swelling persisted, the patient went to another surgeon and they advised surgery. If this patient came to you at this stage, what incision would you take? Lateral, medial, or swashbuckler? Half said we would go for medial approach, the other half, predominantly the other half said lateral. Then after the debridement, the question was, what side would the window be made? Lateral, medial, or just straight through the cloaca? Again, the answers were divided between a lateral window or a medial window. Very few said they will just straight through the cloaca. Next was the size of the window. Half the delegates said they would make the cavity as much as the osteomyelitic region. 35% said just widen the cloaca on all sides. That would be enough to scrape the osteomyelitis. How would you take culture samples, whether you would use a swab stick or a leak-proof container with saline, without additive, Bactec bottles, or formalin with histopathology? Now, multiple options were allowed. Some of you still would go for a swab stick. Even if you are exploring, swab stick is still an option for a lot of people. Half of the delegates said that they would use sterile leak-proof containers without additives, which is the correct option, along with Bactec or blood culture bottles. Additives like saline, like we said last time, would dilute the culture. Formalin bulb for histopathology, very few have agreed that formalin histopathology is required. Again, we would want to stress that histopathology should be sent in every case, because a lot of times there are some, this may not be a case of bone tumor, but a fungal infection can be detected on histopathology in some cases, which would otherwise be missed. Now, the patient was operated by the second surgeon with a medial approach, because the sinus and everything was, the discharge on the MRI and the swelling was seen medially. The culture grew MRSA and was treated with appropriate antibiotics. But the fever persisted, pain persisted, and then he came to us. We repeated the MRI. This is the thing that a lot of people question, that again and again the cost would increase, but unless we know what is the current situation, osteomyelitic picture can change in a matter of days. We must repeat the imaging again before we decide to operate, to know exactly where we stand and plan accordingly. The disease had clearly progressed, infection had increased. If you would come in at this stage, what would you do? Just step up the antibiotics or explore? At this stage, vast majority have said, no, we will explore. There is no point stepping up the antibiotics. When would we re-explore? Stopping antibiotics at 2 weeks, or immediately considering the patient has fever, high counts, ESR, CRP were raised, and was diabetic? Majority have said, yes, we should explore immediately, and that is clinically relevant because the patient might go into sepsis, considering that he already has fever and is a diabetic patient. Again, the approach. It's already been operated medially. Would we take the same incision, go through the same, or in a slightly different way, or a lateral incision, or bilateral? There was a wide spread of answers here. Majority of the people, 28%, I would say majority, but of the people, a lot of the delegates wanted to go bilaterally, laterally, and medially. 21% each went for a medial incision, same incision. and 21% said lateral. There was one option which read osteotomy, converting it into two fragments, then a reaming, and then lavage. How would you make the window? Will you explore through the same window? Would you extend the window or make a separate lateral window? 50%, more than 50% said we'll make a separate lateral window because the primary surgeon had already made a medial window from which the infection had not settled. So make a lateral window, maybe that would give us better access. The other half have said extend the extended window. Would you stabilize? Majority have said yes, we would stabilize. I think now a lot of us would reconsider this answer, having seen a few of the previous cases. If we stabilize, what would be the implant of choice? 42% said external fixator, 21% said an antibiotic nail. Anything else would, any other internal fixation without antibiotic would be risky. Now let's go back to what we did. Our line of thinking was a big enough window is required for a good access for clearing the infected tissue without weakening the bone. Like I said, 20%, at the most 25% of the circumference. Incision should be big enough to allow access to the soft tissue as well as the creation of the bony window. Going back to the classification, I've already explained this type. There are 4 types. I won't be repeating the same thing again. Let's go to where this patient stands. And we can clearly see on the CT scan that part of the cortex was involved, not the entire segment. It's only the medial side where the window was treated and there was cloaca there. But there was no axial instability. So it's not medullary because there is cortical involvement. This is not superficial because there is medullary involvement. This would not be a type 4 because axial stability is not compromised because it's not an infected non-union. Only one part of the circumference involved. So it would fall into type 3. As far as host was concerned, this was a BS or a systemic compromise type B host, which majority people had agreed there. Now, we must identify all previous scars, all drains, sinuses, biopsy sites, all of them must be included in our incision. The MRI was clearly, going back to the MRI, it was clearly an infective process, low on T1, hyper on T2. We added a CT scan here because it gives a much better picture as far as the cloaca is concerned, the previous window, sequestrae, and small areas of cloaca anteriorly, posteriorly, which you would otherwise miss on an MRI. This thick periosteal reaction, you see this abscess between the two cortices, the endosteum and the periosteum. You would miss that if you had not done a CT scan. So evaluating the CT scan, thin slices, step by step gives us a very good idea. And what we must also do is sit with the radiologist and get a measurement from landmarks, maybe from vessel trochanter or the joint line as to how much distance is there from the joint line to a certain sequestrum or a cloaca, because that is information that we can use during our surgery. Decision as far as the window was concerned, it was pretty easy. There was already a medial cortex which was weak. The window had been made, the cloaca were medially. Best was to extend the medial defect, because if we excise the lateral bone, then we're converting it from type 3 to a type 4. It's like creating an infected non-union. The chance of fracture would be much, much higher. The axial stability would be compromised. And in that case, yes, definitely some kind of fixation would be required, either external or an antibiotic rod. Best was to make the medial window. If you're making a medial window, go in from the medial side. Previous scar was also medially. But as orthopedic surgeons, we always avoid going on the medial aspect of the thigh because the vessels are there. So evaluation of the MRI is extremely important. We can clearly see the vessels are far posterior or lower down as compared to the incision is concerned. The incision was much more anteriorly. So we go through the scar and we can directly approach the osteomyelitic cavity, and the soft tissues provide a good cover and the vessels just get pushed behind. So this is the incision we took. We reached the thick infected periosteum. The cloaca were identified, the previous window was identified. We extended the window, made a nice oval window, almost about 15 centimeters in size in the technique that Sir has shown in the previous case. Again, a CM image was used to ensure that we had adequate access proximally and distally, And it's not just about putting the artery, the scoop must go there. We must scrape out all the endosteum. Now, with a reamer in the distal metaphysis, proximal metaphysis, it becomes very difficult to ream the endosteum. It's not just about the medullary canal. We must scrape the endosteum in a clockwise manner. Start at 12 o'clock, go to 1, 2, 3, and in a clockwise manner, come back to 12. That is how we can ensure we've scraped out the entire biofilm, because then hematogenous osteomyelitis also has biofilm. It's not just an implant-related infection that has biofilm. We must scrape out the biofilm in a clockwise manner, proximally along the proximal to the cavity, in the cavity, and distal to the cavity. Like I said, the CT scan helps us in identifying these cloacae. Here we had to reflect the muscle, go on the anterior aspect and make these find these small cloaca which had abscess and granulation tissue within them. And we scraped them, and the image on the right hand side shows that these cloaca were then clean after our debridement. We use small scoops. Bleeding is an issue. So we use gel foam, pack it within the medullary canal. Before doing that, pack the medullary canal with either mops or gauze pieces or roller packs. Ensure that your mop count and your roller pack count is correct after surgery. It's very easy because the gauze can just get soaked in blood and we can clearly miss it. So use radio opaque gauze pieces or roller packs if possible, or use mops to pack them so that we don't miss out and keep the thread out. Then pack them with gel foam. Cultures grew MRSA, vancomycin with stimulant beads were put in after 4 days. And you can clearly see the spread of the stimulant beads, like sir had described, across the medullary canal and deep to the muscle anterior and posterior. But spread it because the zone of action is about 1 to 2 millimeters around each bead. So there's no point packing it just in one area. This was the X-ray and clinical picture at 8 weeks. Patient was comfortable. This was the radiology. The charts showed a clear normalization of the WBC counts. ESR and CRP went from 45 to 30 and almost 40 to 3.7. This is a 3-month clinical picture, and clearly a lot of callus, not callus, thick periosteal reaction and calcification was seen in the soft tissue. Eventually what happens with time is the bone consolidates along the window. The window never closes, but it becomes thick and shrinks in size. And this was the picture at 9 months. It was absolutely comfortable and back to full activity. So what we learn from this case is we must plan the incision based on the radiological pictures. Another thing that helps us is take a video of the patient pointing to various areas where the patient gets tenderness and ask the patient to score it from 1 to 10. So you get an idea as to which is the side of maximum tenderness. Now that is an area that we must explore. So the incision should be around that area. If that area is directly on a neurovascular tissue, the incision may be slightly away from it, but we must access that area. So taking a video, keeping it handy on your phone and reevaluating the surgery also helps us in deciding have we missed out that area or not. Plan the window appropriately and analyze CT and MRI from a surgical point of view. Sit down with the radiologist, have a conversation with them because they also need a surgical inputs. So this was as far as the case we had shared with him.
Thanks a lot, Dr. Menon. There are a couple of questions. Amount of vancomycin. Sorry, before that, if Sarni Madar type 4, then how will you stabilize? So that goes to infected non-union. So that would depend on whether it is medullary, whether it is following plating, and based on case-to-case scenario, we will decide. And we will again discuss it at length in the next module. Amount of vancomycin that should be used, Aditya?
Yeah, so vancomycin, if you're looking at stimulant for 10 cc, 2 grams, and for 5 cc, 1 grams, the stimulant company people generally have an Excel sheet which gives us the amount of antibiotic that can be used for 5 cc and 10 cc for various antibiotics. That is something that we must keep in handy. We'll share that on the group. For PMMA cement, if you're using it for structural construct, then 10%. Otherwise, there are some arthroplasty surgeons who say almost 20 to 30% of the cement amount can be used. So if it's a 40-gram packet, then 4 to 8 grams, although the amount of antibiotic may become very high for that patient, especially Indian patients, based on the weight of the patient. So 10% is a safe value. 2 grams in 20, 4 grams in 40, nothing more than that.
Okay, so now we would discuss what I call a puzzle based on culture-specific antibiotics. Dr. Aisha has already covered this topic, and as I said, Dr. Soman was the one who established Department of Infectious Diseases at Hinduja Hospital, and I must thank him very sincerely for saving life of this patient. So this is a story of a middle-aged person, diabetic, uncontrolled. From day 1 to day 75, he was being treated elsewhere. And from 75 onwards, he was under our care. So day 1, he had fever with rigors. He was treated as malaria. He developed knee pain in a week's time. The pain was continuous. He was febrile. Therefore, an MRI was done and it was reported as medullary infarct. His fever persisted in spite of antibiotics. So about 3 weeks down the line, he had counts, very high counts, almost 26,000. He still had high fever. His PET was highly suggestive of osteomyelitis of femur. This is where we are on day 19. On day 22, that means 3 days after the PET, drainage of osteomyelitis or abscess and osteomyelitis was done with a small cortical window. Here you can see a very small cortical window that is being done. Can you see my, can you see this? A small cortical window was made. Culture was Acinetobacter, which was sensitive to 3rd and 4th generation cephalosporin, but resistant to cholesterol. It was sensitive to cephalosporin, but it was resistant to cholesterol. So this is a first hint to solve this puzzle. The surgeon started antibiotics based on the culture pattern. However, from 22nd day to 38th day, in spite of antibiotics, the fever and pain and discharge continued. His counts varied between 15,000 to 20,000. ESR and CRP were very high. Again, on 30th day, the local debridement was done. Exactly similar sensitivity pattern, but this time the bug was different. That was E. coli. From 39th day to 75th day, various antibiotics were tried. His condition worsened clinically as well as hematologically. These were the different antibiotics that were used, and still he was not settling. So this is a story from day 75. When he presented, he had high fever. His WBC count was 16,000 and high ESR. This is the previous incision site which was draining. He also had an abscess on the anterior aspect of left thigh and abscess on the medial side of left side of ankle. Here you can see there's a abscess there on the medial side of ankle, but he had a right inguinal lymphadenopathy. So the femur was infected on left, osteomyelitis on the left side. He had a soft tissue abscess, anterior aspect of left thigh, that is same thigh. He had an abscess on medial aspect of same ankle, and he had a right inguinal or inguinal lymphadenopathy on the opposite side. So this is a second hint. By then, the osteomyelitic process had increased significantly because as per the protocol, we repeated MRI, did an MRI of the ankle. So there was an ill-defined necrosis on the posterior aspect of medial malleolus with no involvement of bone. So as a surgeon, I thought that this is an inadequately treated osteomyelitis femur, which has gone into septicemia and with multiple abscesses. I mean, that's all I can think. We always try to blame the previous surgeon. We always say that, oh, he has not done a good job. But that was not the only reason for his poor response. That's the third hint. So to recapitulate, he is a middle-aged man, diabetic for 4 years, presented with osteomyelitis of femur for 75 days, soft tissue abscess of 15 days duration, and he has an inguinal lymphadenopathy on the opposite side. Extremely toxic patient with high fever and leukocytosis. 4 times gram-negative bacilli were isolated with exactly similar pattern of sensitivity. That is, sensitive to cephalosporin, resistant to cholesterol. In the hierarchy of gram-negative resistance, generally patients who are resistant to 3rd or 4th generation cephalosporin, also piperacin, also meropenem, will be still sensitive to cholesterol because it was not used for many, many years. So this patient was resistant to cholesterol but sensitive to cephalosporin. So honestly, my brain did not pick up the significance of this. Fortunately, Dr. Soman picked it up and he just asked one question to that patient. Have you visited Goa or Karnataka? And he had an answer. I'll stop sharing now. And if somebody can pick it up, please let me know. You can unmute and let us know. I'll stop sharing. Anyone? Anyone? You can put it on the box also.
One answer, parasitic or fungal infection by Dr. Gandhi.
Okay. Anything else? Now, gram-negative bacilli have been isolated not just once, but 4 times. 4 times. So it is very unlikely that you are dealing with a parasitic infection. Typhus, anything else? In fact, Dr. Aisha did mention briefly that there are some bacteria which are inherently resistant to cholesterol. Infective endocarditis. Now you have multiple areas of frank infection. Osteomyelitis, soft tissue abscesses, a linguinal node on the other side. I'll start sharing now.
There are a couple of more answers.
Yes.
I don't know. Typhus, rickettsia, infective endocarditis.
Yes. So I will go ahead with the story. Can you see my screen now?
No, it's not on slideshow mode. We have to stop sharing and do it again.
Can you see it now?
Yes, we can.
So this is where we were. So as I said, we need to make a big window. So my idea was to make a window like this, a big window corresponding to the signal changes. Now this was the previous window. When I explored, I realized that the window was very small. You can see infected tissue deep inside. And that's the window I made, a big window. You can see deep infected tissue deep underneath. I also excised this soft tissue abscess, which was communicating with the osteomyelitic cavity. I drained this ankle. This is the second debrima. You can see a reasonably clean wound on both sides. So that is the time when we applied VAC. I did not apply VAC on day one. It was only when I realized that there is not much bleeding, then I applied VAC and using a wound contact layer so as to prevent getting that VAC foam stuck to the medullary cavity and prevent excessive bleeding. If you directly apply VAC foam to the medullary cavity, granulation tissue can go in and it would be impossible to take out the foam. So you must have a wound contact layer, either a burn mesh or paraffin gauze. Here you can see we have used a bridge VAC. And this is 85th day. He came to us on 75th day. The 85th day, a very clean wound. Patient has settled very well. This is the shape of window. And these are Dr. Suman's note on day one. Patient has multifocal involvement, high fever, and this can happen. This is the second thing seen by Dr. Suman. This can happen with Burkholderia or melioidosis. So Burkholderia pseudomeli is a gram-negative bug which was separated from Pseudomonas aeruginosa only in 1996. Till then, it was classified as Pseudomonas infection. This is also known as Pseudomonas pseudomeli, a gram-negative infection. It infects humans as well as animals and causes melioidosis. But what is different than managing a staphylococcal infection and Pseudomonas infection? Why should it be different? Now remember, it causes abscesses in muscles, osteomyelitis and septic arthritis, abscess at multiple sites, lymphadenitis. It is sensitive to many antibiotics. But what is very, very important is it has high mortality, almost 40% without ceftazidime. So this is the most important thing about Pseudomonas, Burkholderia pseudomeli. And it has a high recurrence rate without at least 3 months of cotrimoxazole. It is a challenge for everyone. Infectious disease specialist, the microbiologist, as well as orthopedic surgeons to differentiate between Pseudomonas infection and Burkholderia infection. And a very important hint is Burkholderia is generally multifocal, often has chest problems, and is resistant to cholesterol. It is said that any culture of Pseudomonas with such sensitivity pattern is Miss Burkholderia. It is not uncommon in India, but it is often missed. It's also called Vietnamese time bomb, because so many US soldiers, when they went back to United States after Vietnam War, developed this after many years, and therefore it is called time bomb. What is important is these are the risk factors. The ceftazidime is the most important treatment for acute illness, cotrimoxazole for prevention of infection. Now, to go through our story, this is him at 28 days, totally afebrile. He settled very fast. ESR came down. That's at 4 weeks or so. That is 3 months post-op. So I did not give him any splint. I did not fix him or stabilize him by external fixator or internal fixation because of Cernemedar type 3. He had an axial stability. And the wound size, the window size was less than about 25%. So what happens to this window? Such a large window, one is always scared that it would just cause a pathological fracture. Generally, no. if you have got rid of the infection, then the nature starts forming callus at the end and along the edges. So here he is at 1 year. You can see there is a good callus here. The window has started closing. This is the scar. He has got good knee function. Now this is at 6 years. You can see the window has almost closed. There is a good bone formation on either side. And this is at 3 months, 1 year and 6 years. Window is practically closed. And this is at 9 years. You can see there is in the middle, the window is closed. Only at the ends, the window is remaining. Sorry. So the nature forms this window. You have seen the window frame. The nature forms window frames and slowly starts forming bone, which will occupy the vacant area of the window. So to recapitulate, one is the puzzle. Most cases are missed. It's just a tip of iceberg because it's a great mimicker. There's a challenge to identification in lab, challenge for management, and correct diagnosis and treatment is essentially for patient survival. Coming back to our window size, it should be adequate to scrape the biofilm. It should be elliptical. It should not be rectangular. And if it is less than 25 to 30% size of the circumference, there is no need to stabilize this window or stabilize this. Sorry, stabilize this. Shall I stop sharing?
Thank you, sir. Very, very interesting case.
Any questions?
Yes, there are a couple of questions for you, sir. Dr. Aisha has asked, should we create an iatrogenic fracture in diffuse osteomyelitis, like an osteotomy, and then remit retrograde or antegrade, stabilize with an external fixator followed by definitive fixation?
Number one, the aim is to remove all infected material without causing additional damage. So your technique has to be as less traumatic as possible. You can't obviously have a traumatic technique, but as less traumatic as possible. And complete removal of infected tissue. If you create a pathological fracture or iatrogenic fracture, then you are taking it to Cerny-Medard type 4 with axial instability. So you need fixation. You still have to scrape the distal portion because of the funnel shape of most of the long bones. You will not be able to scrape adequately by reaming. Still, you need to scrape, use long scoop and scrape. And as I said, you take back everything by at least 6 to 8 months because this fracture would take 6 or 8 months to heal. Here, we have just made a window which has not weakened the bone, but caused, or we are successful in scraping the biofilm completely.
Another question was indications of PET scan on bone scan and osteomyelitis.
Especially when you are suspecting multifocal lesion, that is number one. Number two is in presence of metal or implant. It is easier to do a PET scan because if you do not have facilities for Mars MRI, then you can do a PET scan. And thirdly, when you are dealing with radius ulna fracture, we will discuss that in another scenario, radius ulna fracture, and you are not sure whether radius and ulna both are infected or only one of them is infected, then it's worthwhile doing a PET. You would like to add something, Dr. Aditya?
Most, I think all the points are covered. There are no more questions in the chat box.
Tanay had unmuted himself and stopped his video. Would you like to ask something, Tanay?
Yes, sir.
Yeah,
sir, we had discussed about a case, sir, where I had to where I asked for the opinion whether I should go for skin graft or VAC,
yes,
and it's
correct.
selected.
So at this point, we will discuss your case.
Yes, sir. Thank you, sir.
Can you share the screen?
Unfortunately, I could not prepare the PPT for that, sir. I have sent that if it's not too inconvenient, sir. I have sent the same images on the WhatsApp. If we could open it up, I'm really sorry for that, sir.
See what happens.
Culture report.
Becomes, can you share that, Dr. Aditya? Becomes little difficult to.
Yes, sir. I'm really sorry for that, sir. But
No, not
I
an
got
issue.
done with the case, and I just received the culture report, sir. Unfortunately, I'm in a tier 3 city where there is no microbiology.
Not an issue. We will next few days we will discuss that. We will prepare a present, or you prepare a presentation and we can discuss.
Yes, sir. I'll do that.
No problem.
I just need an opinion, sir.
100%.
Yes, sir. So the pus culture report I have received just says gram-negative bacilli, and he could not isolate the organism because he said, I am not a microbiologist and I do not have access to all those tests and everything. And the intermediate sensitive antibiotic is only sparfloxacin, which is not available here, and everything else is resistant. But as we discussed today, the patient is pain-free and free of any kind of fever since the last 3 to 4 days. So what should I do now, sir?
Will you just make a presentation and put it tomorrow? I'll respond. We will respond tomorrow.
Yes. Thank you, sir. Thank you.
Otherwise, it becomes very difficult to respond.
I understand. I'm really sorry for that,
problem.
Sir.
Not an issue. Not an issue.
Thank you, sir. Thank you, sir.
So,
So,
last question in the chat box.
yeah.
Dr. Akshay is asking, when we have a chronic osteomyelitis with a sequestration only in the cortex and on CT and MRI, medullary canal is not involved, we need to open the canal.
So if there is a cortical sequestrum, open only that area. Do not go into the medulla because you will unnecessarily infect that. So
there are any more questions? Yeah. Yes, sir.
So it is best not to do that. Yeah. If there are no more questions, I will discuss the case number 1 first.
No questions, right?
Yeah, sure. Can you see my screen? Okay. So this was a case from closet, and what we call is what else could have been done. You have gone through this case. Patient came in with signs suggestive of severe infection. There was a visible swelling. When he presented to us, there was a visible swelling in the thigh. There was a biopsy mark. He had a flexion deformity. He had raised ESR, raised CRP. He has. So when I traced the history with all these findings and a sort of periosteal reaction, which was suggestive of tumor, the MRI was highly or reported as suspicious for malignant neoplastic lesion. And therefore, he was referred to an oncosurgeon. Oncosurgeon felt that it is more likely to be infection. So he put in a J needle, the culture was MSSA, and then he was transferred to me. The MRI consultant reviewed the report and said, no, you are right. This is a soft tissue as well as osteomyelitic lesion. So this fits into definite osteomyelitis. Let's skip all that. I take you back about 50 years. 1978, NID had laid down these principles. Antibiotics are effective before pus forms. 2, they cannot sterilize avascular tissues. 3, they prevent pus formations once you have removed the pus. So they will not work in presence of pus. Pus removal restores periosteum and restores the blood supply, and antibiotics should be covered or continued after surgery. So all this still holds true in spite of tremendous improvement in or development in antibiotics. However strong antibiotic may be, it will not be effective once pus forms. So that was the culture. So this was the surgery that I had done. I excised the biopsy wound. There was a granulation tissue on the lateral femoral cortex. Pus came out from here. I made a small window. You can see the size of the window as compared to whatever presentations we have made. The small size window, lesson to learn from for everyone. I made another incision distally. Again, made another small window here distally to drain pus. Our ID consultant started on appropriate antibiotics. I used Stimulan. Many of you have said, at least 50% of you have said that I made, they were reasonably happy with whatever I had done. This is a 2 weeks, very comfortable patient. Postoperative course was uneventful. And at 5 months, patient was very happy. Unfortunately, he lifted weight, turned, heard a noise, and developed severe pain. This is him at 5.5 months. There is no fever, no local warmth. ESR is 23, CRP is normal. What could be the cause of the problem? Either a small window or a large window. I have already answered that. It was an inappropriately or inadequately treated osteomyelitis. And therefore, one has to do an MRI first and avoid close reduction or nailing or any metal implant till you are absolutely sure that there is no infection. So first step is an MRI. So this is his MRI, suggestive of a displaced pathological fracture and extensive signal abnormality in anterior and lateral compartment of thigh. A combination of infection and bone infarct with necrotic area. So clearly the disease process had progressed and we now have a pathological fracture at hand. So what are the problems? Recurrence of osteomyelitis, pathological fracture, osteomyelitic process, middle third, lower third, and patient was operated by me. That always puts you under more stress. So what we have to do is eliminate osteomyelitic process as well as fracture healing. So what is the aim? Aggressive debridement, appropriate antibiotics, and possibly local antibiotics, excellent monitoring, and some form of stabilization. For fracture healing, we need to have some kind of stabilization. Either external fixator or a ring fixator or antibiotic nail followed by nailing or a plate, and possibly bone grafting. How do you debride? Do you make a larger window, or it will certainly help us in doing a thorough debridement, but it will also weaken the bone significantly. Can we ream through the fracture site? Yes, but it may not be as good because again, the distal canal is wide. So you will not be able to debride by just doing a normal nailing, reaming. Again, stabilization, If I do an external fixator, possibly there are less chances of recurrence of infection. But yes, chances of delayed or non-union are high and chances of pin tract infection are high. So how do you prevent delayed or non-union? Use a non-anatomical but stable reduction. We discussed that at length in open fractures. If I scrape through the fracture site, yes, I can do that reasonably well and then add some kind of fixation. In this case, I decided to use an LRS. So I did a non-anatomical but stable reduction and used an LRS, put in vancomycin beads. Here you can see I've got a good docking and patient, the fracture has already started healing. So at about 8 weeks, I took out the beads and addressed that defect with autogenous grafts. And this is him at 8 months, no recurrence of infection. This is at 30 months post-op, well-healed fracture. He has a range of movement of about 100 to 110 degrees. So all in all, what are the lessons that I learned? I learned several lessons. One is something which I have been stressing again and again. Adequate size of window to do a good thorough scraping. Number 2 is have a good or suspicious mind. Repeat an MRI even though patient is reasonably asymptomatic at about 4 months. If I had repeated an MRI, maybe I would have picked it up. Third, that non-anatomical but stable reduction resulted was a little bit too much. I use an LRS. All the shank screws have to be in one line or one plane. If they are not, there is likely to be a secondary displacement, which happened in this case. Fortunately, I could get away with it. Thirdly, whenever you are using an external fixator on femur, and if you use it for a longer time, there are good chances that you will lose range of movement. In this case, before fracture, he had an excellent range of movement. Post surgery, post healing, he had only 0 to 110. Yes, I got away with it, but I could have had a far better result. Any questions now?
There are no questions for the chat box.
There is a question on chat box.
No, there is no question on the chat box.
There is no question on chat box. Okay, so the last presentation is just a short presentation as to why aggressive debridement or the magic of debridement. So a young man presented with a discharging sinus on the medial aspect of thigh for 10 years. And just 6 months prior to presenting my presentation at our place, he had developed a pathological fracture. So he approached us with a pathological fracture and sinus on the medial aspect of thigh. Here you can see the medullary signals and he has a fracture. Therefore, it obviously falls into type 4 or stage 4 Sarni-Medar. He's a young man, no comorbidities, so host type A. The plan was to do an aggressive debridement or excision followed by some stabilization. Here you can see I've excised the sinus, gone up to the bone, that's the sinus tract, that's the non-union site or pathological fracture site. Here you can see that's the sinus tract, that is one fragment, and I have excised it with, that's the non-union site. That's the bone, proximal bone with canal closed. And this is the area I have excised. We opened the canal and scraped the canal from inside. Here you can see we have opened the medullary cavity and scraped it thoroughly. And this is him. Initially, I had used a tourniquet for debridement. Going from the medial side was always troublesome, but we could excise the large, some segment of the bone, scrape the canal. And since the bleeding was little bit excessive, I packed the wound, and here you can see this mop with radiolucent lines. This is a very clean wound on day 4. And this is a great lesson I learned. I put these beads inside as well as outside, put them even in popliteal posterior aspect of femur. This is him on 4th day. Since the osteomyelitic process had extended distally, I decided to defer stabilization, because putting an external fixator here would be either a joint spanning fixator, which is not going to give me adequate stability, or I had to go through this area which was infected. So I thought might as well keep him in Thomas's splint for some time and then come back for external fixation. 4 months. He just lost for follow-up. He came back at 4 months and said, "Sir, you had told me for removal of these beads at 6 weeks, but I could not come. And now remove the fixator, remove the beads." Now here you can see there are some beads on the posterior aspect, but he actually came walking. Here you can see he's able to raise, and that time the whole thing was engulfed in callus. So I just could not take out the posterior beads. Could take out a few beads. This is 8 months follow-up. Here you can, he is not using any stabilization. This is a scar. That's the range of movement he has got. This is the video. In slow, he is walking without any support. Oh.
I think, sir, there's network issues. Till then, I'll take a question. Dr. Durgesh has asked which of these superior, beads or blocks in antibiotic space. We'll answer this with a presentation in coming sessions, but in short, if I can tell you, whenever there's a gap, use a block, because that fills the gap like a masculine technique. So it not only gives stability, it helps induce a membrane. Beads can be used to pack the medullary canal or the soft tissue around it. So like I said, cement block only when there's a gap, because a block can be filled only in a gap. You can't stuff a cement block inside a medullary canal. And beads within the medullary canal or in the soft tissue around it in case you want delivery. Beads can be replaced with stimulant beads, I mean the PMMA beads or stimulant beads based on whatever the expense is. If you're planning to go in again for a bone grafting, then PMMA is fine, but we must go in at about maximum 6 weeks to do the bone grafting, remove the bones. I think sir is back online. Sir, can you hear us? If there are any more questions, feel free to unmute and ask. You can start your videos now because practically all the presentations are done.
I have made the presentation in the meanwhile and shared it on the group, sir.
Okay. Okay, let me see if I can share it. Okay. Issues trying to access my WhatsApp on the laptop. So we can't hear you. We can't hear you.
Can you see now? Can
Yes,
you hear me?
We can see it. Yeah, we can hear you.
Sorry, friends, my computer certainly needs servicing. So I'll skip the videos. This is him at 16 months. He is able to sit cross-legged. He has a decent range of movement. The fracture is healed completely. And this is at 25 months. You can see it's completely healed in reasonable alignment and has a decent range of movement and excellent function, drives, runs, does everything. So these are unbelievable results by just thorough debridement. This is a very, very unusual thing. Please don't quote me or please don't think that by just debridement you will have excellent result in non-unions. All I am trying to say is how vital is debridement. Okay, I'll stop sharing and I'll stop share. Yes, can you present? Since we have started late, maybe we can have this for about 10 minutes. Yeah, please go ahead. Ortho TV there? Ortho TV?
Are you there?
Because he'll have to be made host.
Yeah, even I'm trying to download this presentation. It's taking too long.
I'll just try it on the tab, sir. I'll just try to open it on the tab, sir. And I'll try to share it here, sir. Yes, sir. I will share it from here, sir.
I don't know if you have permission to share screen. Try it once. I've almost downloaded your presentation.
I don't have the permission, sir.
Yeah, 1 second. I'm almost done. Give me 1 second. Okay, then I'll share screen. You can talk and tell me when to change the slide. Yeah, this is Dr. Tanes.
Thank you, sir.
Dr.
So,
Tanes.
yes, sir. So this was a 30-year-old male, history of RTA, a bike accident 7 days back. He's a villager, so I suspected all kind of dirt and everything. He presented to me within 24 hours with a compound injury on the dorsum of foot, Gustlow-Anderson grade 3B of dimensions 4 centimeter by 7 centimeter on the dorsum of the foot, primarily sutured in a government setup, sir. So this was the wound. On the left, we can see the wound. And the X-ray shows a metatarsal, third metatarsal fracture along with medial cuneiform fracture, and on the lateral, on the oblique image, we can also see an interarticular calcaneus fracture. So I went ahead, I debrided surgically well, and I repaired the tendons, and I also left it open because I did not have the VAC available that day, and I sent a culture. And 2 days later, the VAC came. So I applied a skin graft. I had a very good wound bed. Sir, if you could show the next slide. I had a good wound bed. So I went ahead and I applied skin graft and a VAC over it on a continuous mode at gradually increasing to 125 mmHg. And ever since then, he's on Piptaz IV, just that. He has no pain, no fever without the need of any kind of painkiller. So now, and unfortunately, I have no access to a microbiologist here. So they just gave me a report with gram-negative bacilli, which is resistant to everything apart from sparfloxacin, and that sparfloxacin is also not available here. So what should I do now, sir?
Sorry, you're muted.
When was the culture taken?
On day 1, sir.
No, before debridement, after debridement.
Before debridement, the first thing I did was I went inside, took a deep culture, and after that I did the debridement. After that I gave the wash. But as discussed earlier on the lectures, the patient came. I started him on antibiotics, augmentin, gentamicin, and metronidazole. After about 4 hours, I took him into the OT after I received all the blood investigations and everything else.
I think Dr. Aisha will have to be consulted. We'll talk to her. And Dr. Aditya, you have any suggestion?
Yeah, I think she will tell you to ignore the report. One, it was within 24 hours of the injury, correct?
Yes, yes, sir.
Even though they had sutured, you opened it up within 24 to 48 hours. Did
Yes,
the
7 days, 1 minute.
Good.
You opened at 7th day.
No, sir. I opened first on within 24 hours only. Now it is 7 days.
Sorry. Well, what was that 7 days?
Now it is 7 days post first surgery.
Nothing.
Okay.
Nothing.
Okay. Yeah.
Yes, sir.
I think he's done a thorough debridement. I think you've done a thorough debridement day 1. That was a question. It wasn't like mostly injury. Been a good antibiotic. You applied so the backup is good.
But we cannot hear you clearly.
Clinically doing better, no fever, pain. Now, can you hear me?
Yes, sir. Yes, sir.
Hello?
Yes, sir.
Yeah. So you've done a thorough debridement within 24 hours. You've given them antibiotic. You've covered the wound in, I think, 72 hours or 40, whatever, after the vac. And
Yes,
the patient is clinically better. So just hang on and I think ignore the report, sir. That's what Dr. Aisha would say.
Okay, sir. Okay.
Just ignore it.
And
So should I
as per the international protocols also, at the most 24 hours after you have a cover, antibiotics to be given only for 24 hours after the cover.
Sir, actually, I haven't removed the vac yet, so I'm not sure how far has the skin graft been accepted.
Yeah, but then, okay, we'll talk to her.
How many days since the skin graft?
Sir, 5th day today.
So why are you still keeping vac?
Sorry.
Why are you still keeping vac?
Sir, I'll be removing it.
Remove the skin graft right now. I think you can remove the vac now. Yeah.
Yes, sir. I'll be doing that tomorrow morning, sir.
One more question.
Yes,
The
sir.
calcaneum appears to be just a crack fracture. Am I right?
Yes, sir.
Do you have a CT?
So patient was really not affording, sir.
It's not an issue. But then why did you fix it? And how did you fix it?
Sir, when I took better images on Siam, I saw that it is just intraarticular, undisplaced intraarticular. So I just fixed the intraarticular component so that it doesn't displace even if patient tries to walk when he feels better.
Okay. But especially in a case like this, it's best to avoid metal as much as possible.
Okay.
And if it is just intraarticular, best thing is to, it is just a crack.
Yes, sir.
Calcaneum would heal well. This is just a thinking. One
Yes,
way
sir.
of looking at it. One way of looking at it.
So I put a percutaneous pin posteriorly where the skin was clear. And I thought if the patient feels better and puts weight, so it would still save the collapse.
Okay. As I said, there are different ways of looking at it. Now that you have already done it, that's fine.
Yes, sir. Also, sir, I wanted to ask a query. How far do you think are loops beneficial in debridement, sir?
If you are used to it, very useful.
Okay.
Most of us don't really use it well, but there are people who use it. Some orthopedic surgeons, especially pediatric people and hand surgeons, use it extensively, and it's very useful.
Okay. Thank you, sir. Thank you.
Especially in open fractures. Especially in open fractures.
Yes.
Okay, friends. So, what all did we learn? Tanay, in fact, you can tell us what all did we learn today, or what all did we discuss today? What new things you picked up?
So today I was taken, my mind was taken off a lot. The load was taken off my mind when you presented that the symptoms also matter a lot, not just the report, which I also wanted to confirm. So tabulating and charting of those symptoms is very, very important. And then, of course, a thorough debridement, surgical debridement is the key. And a stable fixation along with the debridement would also improve the chances of disappearance of infection as such and preventing it from further getting infected. Sir.
Correct. Then acute and chronic osteomyelitis can present together or can be there at the same time in histopathologically.
Yes.
So the classic classification of acute osteomyelitis and chronic osteomyelitis and treatment based on that is not appropriate in today's world.
Yes. Sir.
Anything else? About the size of window.
Yes.
Size of window should be such that you are able to access the entire thing. And shape of the window is important to prevent a fracture.
Yes, sir.
Anything else, Sir and Aditya, you would like to add? Dr. Thakur, would you like to add something?
No, nothing. We have covered everything very well today. And overall, it's been very effective, whatever we have said. So nothing more.
Thank you, sir. Dr. Aditya, anything about the classification?
So we learned how back classification has helped us clinically take up all the factors, bacteria, soft tissue cover, bony host factors, and apply them in the real world. So it just shows us that we need to go in, diagnose early, go in early, and get the best outcomes. Because the more the patient becomes complicated, the better, the worse the quality of life becomes. And fixation is not necessarily required if you've made a window. So take home one of the biggest things.
So not every time you need to stabilize, and not every time the osteomyelitis can be treated by reaming. Reaming would not be useful in every case. Yeah. So these are a few things that we learned. What we will try and follow is classify every case of infection into both these groups, both these types of classification, and then make presentation. So we will be able to drive home that point or importance of classification. Anyway, it's already 27 minutes past 9. So thank you very much, friends. See you next Saturday. Bye-bye.
Thank you.
Thank you, sir. Thank you, everyone. Tanay, I'm sure we'll see a healthy skin graft tomorrow on the group.
Thank
And
you.
the
Yes.
patient can stop
Thank you,
And
sir.
the X-rays.
Yes.
Okay. Bye-bye. Bye.
Thank you.
Thank you, sir.